Hello, it's Beth Wright, and I am providing your podcast for Unit 3, Nursing NUR 236. And this is Chapter 9, Drugs dealing with the hematopoietin disorders to enhance immunity. So I have your exemplars listed, so those are the ones that you need to work on and definitely study about. So we'll be talking about each of those here in just a second. Let's first talk a minute about the whole process of hematopoietin and immune process that helps the body stay healthy. So we're talking about stem cells here. And of course those are in the bone marrow, and they differentiate when they replicate. And some cells are exactly like the original cells and are retained in the bone marrow to maintain a continuing supply. And some reproduced stem cells differentiate to form other types of cells. And the earlier offspring are committed stem cells, and these become a particular type, and they produce a cell type in a specific cell line, and we refer to those as colony forming units. So just think about back in the day when the United States was formed, how they had colonies developed, and were in specific colonies. So these are also, you'll see them with the acronym CFU. And so here we're talking about our cytokines, and our cytokines, I love those cytokines. I think of them as our cousins, cytokines, our kinfolks, because they come to the rescue when we need help. But they are small proteins that are released by cells, and they affect cell-to-cell communication. And now these include those colony stimulating factors, the interleukins, and the interferons. They regulate a lot of different cellular activity, and they act as chemical messengers among cells and as growth factors for different blood cells as well. And you can see there on your notes that they're involved in a lot of different responses. Of course, the hematopoiesis, they come to rescue in inflammation, with cellular proliferation and differentiation. They're there for wound healing and for cellular and humoral immunity. Just a little bit more about this. We've already mentioned that they're chemical messengers and the growth factors, but they perform by binding to receptors on target cells, and they trigger alterations of gene expression in those target cells. So that's basically how they work. So, do cytokines act by blocking receptors on target cells? True or false? And what did we just say? No, they don't act that way. They act by binding to receptors on target cells. Okay. So our colony stimulating factors, they help stimulate red blood cells and platelets and granulocytes, which are our red blood cells. And part of those granulocytes are neutrophils, basophils, and eosinophils. And granulocytes, again, are our white blood cells. I think that's what I said. And also the macrophages are our granulocytes as well. And then monocytes act as macrophages, and of course then there's other cell types. These substances are found to stimulate formation of colonies of granulocytes. Those are called granulocyte colony stimulating factors. And for the macrophages, they're called the macrophage colony stimulating factors. Okay, the interferons, we've talked about those in the previous unit, but remember that they interfere with the replication of the virus or other cells, and they activate that natural killer cells in the immune system. The interleukins affect the immunological cell response by either stimulating or suppressing whatever is needed at that point. So let's talk about now getting into our specific types of cells. So erythropoietin has to do with the erythrocytes, and the erythrocytes are our red blood cells. Erythropoietin is a hormone secreted by the kidneys, and it stimulates the red blood cells, and conditions that might trigger that production is when someone's hemorrhaging or anemia, COPD, and high altitudes. Our immunity indicates, the whole immune system is just, to me, it's fascinating, but it can help with detecting and eliminating foreign substances, and it regulates the whole homeostasis and repair. It can identify and remove injured, damaged, dead, or malignant cells even. Our immune cells are our white blood cells that circulate in the blood and lymphatic system, and it's very complex, but it's fascinating when you read about it, and I think I posted something in Unit 2 to help try to make some common, or not common, but simplify that a little bit. But also, they have the ability to circulate and migrate, and it just amazes me that, it has the memory of previous antigens and that kind of thing. And especially important in the phagocytic immune process are our neutrophils, monocytes, and lymphocytes. Now, when we have a decrease in our red blood cells and our white blood cell production, we can have several causes, for this to happen. With red blood cells, of course, hemorrhage, any kind of blood loss, cancers, medications such as chemotherapy or, other medications as well. And when we think about anemia in itself, it results in a decrease in the oxygen carrying capacity of the blood, and of course causes, hypoxia within the tissue and within the cells. We have our heart that kicks in trying to try to compensate for that loss of oxygen carrying capacity. And so we initially have an increase in our cardiac rate, our cardiac output, and our heart rate. But, over time, the oxygen demand becomes greater and greater than the supply, and of course we start getting more clinical manifestations such as hypoxia, muscle weakness, fatigue, and pallor, skin color, that kind of thing. With our decrease in WBCs, obviously we're going to see a risk of infection, and our clinical manifestations are going to be a fever, sore throat, things of that nature. Our lab work, we're going to be looking at our CBC, both the red blood cells, white blood cells. With our white blood cells, we want to see that CBC with the differential that gives you your neutrophils, basophils, eosinophils, monocytes. And with our CBC, also with our red blood cells, we want to pay attention to our hemoglobin and hematocrit, but mostly our hemoglobin. I put a note down here about the ANC. So the ANC is the absolute neutrophil count, and that is a value that you've learned. You learned it in cellular regulation of how to come about that amount, but we should be at 1,500, and some references say 2,000, but anywhere from 1.5 to 2.0 indicates that we're in good shape as far as an infection risk. If the patient is lower than 1.5, then we are getting into a risk of infection and getting into trouble. This is something that folks with receiving chemo, they will look at this a lot, and many times they'll delay chemotherapy based on that amount, that ANC value. So, it could mean that they lose a chance of getting their chemo if that is, in fact, too low. So, immunostimulants are the drugs that we're talking about here, and they help to restore the normal function of getting us an increased amount of either our red blood cells, or white blood cells, or our platelets. So the first one we want to talk about is the one for treatment of anemia, and I put out there erythrocytes because we're talking about erythrocytes with anemia, our red blood cells. So darbepoetin and epoetin are the two drugs that you have for as your exemplars, and of course they're going to increase that red blood cell production and help combat the anemia and other signs and symptoms of weakness and fatigue and shortness of breath, and also help to keep the patient from maybe having to receive blood transfusions. The route of administration is sub-Q or IV, and there are some, pretty strict guidelines for this. If the hemoglobin is greater than 12, then it cannot be given. It has to be stopped, okay? Adverse effects may make the patient feel worse at first, but with time, it will improve. It can increase the blood pressure and increase risk of cardiovascular accidents and problems and thrombosis, so we definitely will have to assess. So a contraindication with the epoetin is actually uncontrolled hypertension, of course any hypersensitivity, and so we have to be watching about that, checking the patient prior to them getting the medication. Also, epoetin is not effective unless there's a sufficient amount of iron in the body, so the patient may have to actually take an iron supplement. Evaluation is crucial with these medications, especially if we put someone at risk for having a stroke or heart attack or something like that, and with their blood pressure issues and with their hemoglobin issues. So we must evaluate for those adverse effects. We must also evaluate, is the patient feeling better? Is the patient, is their strength improved? Are they less fatigued? Are they less short of breath? One thing about trying to remember these drugs, if you look at both of these, they have epoetin in it. And if you think about the E of the epoetin and darbepoetin, think the E for erythrocytes, and erythrocytes will help build up the red blood cells. So just maybe a corny way of how to remember this. So I got you a pictogram here, and you can look, it's kind of silly. It's got the kidney there talking to a red blood cell. Anyway, it talks about how this medication, epoetin, works and things to watch for. So you can read that. Okay, so our nursing process definitely is going to be, assessing the patient as we talked about. We're going to, assessing with for any of those contraindications. Make sure the patient needs the medication. Is the indication present there? Lordy, we don't want to give a patient any of these types of medicines if they don't need it. So identifying the patient, identifying the need, and then also checking the blood pressure, those kinds of things, the CBC, the lab results as well. We also have our administration things, so be sure to read about that. Sub-Q, you want to have your proper equipment for that. IV, you also want to make sure we're in the right place for that and in the vein. And of course, our evaluation is going to be monitoring for those adverse effects. We've got to check that blood pressure, make sure it's in a safe range, and you may see nausea, vomiting, diarrhea, or joint pain with this as well. Also, an increased risk of myocardial infection and infarction and stroke. So if there's an issue about stroke, we want to check that mental status changes, make sure there's nothing going on there, any chest pain, or decreased cardiac perfusion. Also, evaluating for therapeutic effects. So use in special populations, children can receive this and they base it on the weight and the hemoglobin level. Premature infants cannot receive it because it contains a benzyl alcohol, which is toxic for children. Older adults, you're going to expect to see similar results with your your adult patient, but as always, they're more at risk for adverse effects because of all the things that go on with aging. Okay, medications to treat neutropenia. Okay, so this one is our granulocyte colony stimulating factor, CSF. And so again, granulocytes, we're talking about your white blood cells, we're talking about our neutrophils here, okay? So the medicine is filgrastim, and we use this when the patients have low ANC because the patient's at risk for infection. The injection is once daily until the blood count stabilizes, the ANC stabilizes. It can be sub-Q or IV, and they mention not to shake the medication and not to give it 24 hours before or after chemotherapy. And it may take around 2 weeks or longer before it works. So, filgrastim is the prototype for this type of medication. It stimulates the blood cell production by the bone marrow, and it's used with bone marrow with patients with bone marrow transplants or chemotherapy induced neutropenia. Again, we got to look at that ANC. Below 500 is high risk for infection. And adverse effects with this medication can be drowsiness, fatigue, flu-like symptoms, nausea, and bone pain. And contraindications are any one known to have sensitivity to a drug or any kind of E. coli derived protein. Now, a few ways to remember this one. We know that granulocytes, granulocytes are white blood cells, are neutrophils, and so you see that in filgrastim. So that may be one way for you to remember that. Another way is you see the fil at the beginning of this word. So think about this. Fill them up and fight. Fill them up to fight, okay? Fill them up to fight. White blood cells fight. Okay, fill them up to fight. So again, maybe corny ways to remember these, but nevertheless, just trying to help. Okay, pegfilgrastim is another type of the GCSF medication, and the PEG part of that is means that it's pegylated, and they what they do that you'll see that in front of words or generic medications a lot of times, and it's that version. It's made to last longer in individuals. So it's one injection per sub-Q per cycle in most cases, and it's given 24 hours after the chemo. They should not take it at 14 days before chemo, and it's given at 24 hours after chemo. It's contraindicated in patients with sickle cell anemia or any kind of allergy to the filgrastim. May have bone or body aches after the injection, and serious side effects are spleen rupture. Pain in that left shoulder could be a warning sign, so we have to watch for that. Also, acute respiratory distress. It can happen with this, so definitely, we got to be watching about that. Do a good respiratory assessment. Again, a way to remember this, it's got your GRA in there for granulocytes. Peg, fill, so fill, there's our fill. Fill it up to fight with your WBCs, fighting. The other thing, I'll talk to you about that in a minute. All right, so your last colony stimulating factor is your sargramostin, and that is the GM because it's your granulocyte macrophages, a colony stimulating factor. Okay, and these are used to help with building up those macrophages. And it's used to treat patients who undergo bone marrow transplants for Hodgkin's, non-Hodgkin's lymphoma, or acute lymphoblastic leukemia. So it also promotes that engraftment to take place and function of the transplanted bone marrow. So definitely we gotta help with evaluating for adverse effects, evaluating for positive effects, assessing that patient. Do they, in fact, is this indicated? So we want to be sure about that as well. Now, the last three drugs that we talked about are your granulocyte colony stimulating factors. All of them end with STIM. So again, another way to try to remember these. So with our nursing process, we've got to assess patient indications, make sure it's the right patient. We got to assess those labs. We got to assess blood pressure, cardiac status. Where are they on their CBC and liver function and renal function. We've got to know about administration. We've got to evaluate therapeutic effects and adverse effects. So never forget your nursing process. Interferons, we've had that again once before. Remember, it interferes with your replication there, and it has an anti-tumor effect too for certain medications such as multiple myeloma and renal cell carcinoma. And it's also treated for hairy cell leukemia, Kaposa sarcoma, which we studied about those previously. It's administered sub-Q. There are some IM, and it can be given IV. It's usually given 3 times per week, about the same time every day, but at least 48 hours apart. Adverse effects are like our flu symptoms, psychiatric complications, remember about that, severe depression, psychosis, and suicidal behaviors. They can also have chest pain, alopecia, anemia, thrombocytopenia, and neutropenia. So don't forget about your nursing process with this. And then the interleukin oprilvicin is for our platelets, our thrombocytopenia, and it stimulates platelet production. It's limited due to ineffectiveness in severe thrombocytopenia, and it's highly toxic. It is a recumbent interleukin. Remember, any type of that recumbent is where they put things together, and it stimulates the platelet production, and hopefully can help decrease the need for platelet transfusion. So I thought of a way for you to try to remember this one. It's very corny. Oprilvicin, okay? Oprilvicin. Say the word, Oprilvicin. Fix Patsy with a low platelet count. Oprilvicin, fix Patsy with a low platelet count. So, thinking of the P's for the platelets there, okay? All right, so sample questions. I've got a couple of them for you. The nurse evaluating a patient on darbepoetin would consider the medication effective when? Okay, so here you got to know, what is darbepoetin? So it's got the epoetin there, epoetin, okay, epoetin, E for what? E for erythrocytes. Okay, so we got to know about erythrocytes here. And we're evaluating to make sure the medication was effective. So if we have someone that has had a low red blood cell count or low erythrocyte, then would we see petechiae, hemorrhages, and bruises fading? That's more going along with their platelets, right? Petechiae, hemorrhages, and bruises. Okay. What about B? The patient can climb stairs without dyspnea. So does someone with anemia or low red blood cell count have shortness of breath? Okay, yes. So B is a definite possibility there, right? How about C? The absolute neutrophil count increases. Okay, is that having to do with our red blood cells? No, it has to do with our white blood cells. And the temperature is 98.6, which is a normal, or what we want to see, temperature, average normal temperature. But does the temperature have anything to do with darbepoetin? No. So the answer is B. Okay, another sample question. A patient, nurse is caring for a patient taking oprilvicin for leukemia. Would teach the patient to avoid. Okay, so it's the P, Pril, Patsy, poor Patsy, okay, for low platelet count, okay. So we got to know again, what is the medicine for? So the nurse caring for the patient that's taking this and would teach the patient to avoid aspirin products and alcohol when which of the following lab is noted. Okay, so platelets, we're dealing with bleeding. The first one is our hemoglobin, and it's for patients who are sick, we probably are okay with that 11, right? Okay, what about our platelet count for B? Is that a good platelet count? So you got to know your labs on this. Our absolute neutrophil count of 1.5. Does platelets have anything to do with the absolute neutrophil counts? No. D, WBC count of 4.5 to 11. Okay. Does it have anything to do with WBCs? No. Okay, so our correct answer is the platelet count, 20,000. That's really low for a patient. So we want to avoid aspirin because that can make us bleed even more. Okay, that concludes your podcast for this unit, for this chapter.